Okay, the title of this talk is Approach to ILD, not Introduction to ILD. It's a little bit of a slight difference. This was originally designed to be done in July mostly for the first years, but things came up. But basically, this is sort of a way of a general overview of how one should approach ILD to come up with a diagnosis and, to a lesser extent, management. And how a patient might present to you either in clinic or inpatient consult is really either symptomatic with progressive dyspnea or a cough. They may present to you with an abnormal chest X-ray or CT, or to a lesser extent, sometimes they may come in with abnormal PFTs. And that's how you start. But unfortunately, the clinical presentation for all the different ILDs that are out there are quite often very similar. The symptoms, progressive dyspnea is very common. As I said, a cough. Less common but still present could be pleuritic chest pain, hemoptysis, not as common. On physical exam, it's basically crackles, some clubbing sometimes, and some signs of right heart failure. And PFT show restriction in DLCO. So because of that, we need to come up with a systematic way of approaching ILD that allows us to get at the sort of decrease and hone in on the limited number of diagnoses that ILD can be. So first, before we do that, it's good to sort of understand the anatomy of the interstitium when we're talking about ILD. So you can't use the mouse. So basically, the interstitium is composed of the parenchymal interstitium and then the interlobular septum. So you can see that this is an alveolar space, another alveolar space, and the interstitium's here. You have the epithelial cells lining the alveolar airway, and then you have the epithelial cells lining the capillary, and they share the same basement membrane. This is the capillary, the blood supply, so that's sort of blood supply, and this is airway, which we'll get to in a minute. And then you have the parenchymal interstitium that contains the bronchovascular sheath. It contains lymph nodes, the occasional macrophage, the occasional fibroblast, sort of sitting there. And then when you get injury, the injury can occur in two ways in ILD. It can be inhalational or circulatory. And you subsequently will then develop epithelial cell injury, and you can get loss of the basement membrane integrity. And then you get migration of inflammatory cells. Once this basement membrane gets injured, it causes the release of chemokines, which then inflammatory cells come in systemically and cause lots of problems, which eventually fibroblasts come in. It's been shown they're from the lung, but sometimes from the bone marrow itself, and they come in and they start as myofibroblasts, and they develop scarring and fibrosis, and pulmonary fibrosis, as a result of the injury. So as you can see from this, that's why ILD is not perfectly interstitial disease. It can also involve the airway because the basement membrane is extravasated, and you can get involvement of the airway. So inhalational injury would be things like, HP, respiratory bronchiolitis, panbronchiolitis. The lymphatics that are involved, sarcoid, lymphangiatic spread of cancer, pneumoconiosis in terms of drainage of the dust. So the pattern can sometimes help you with that. It's useful sometimes to split ILD into idiopathic and known causes. So the idiopathic causes are here. We all know these: IPF, NSIP, COP, AIP, DIP, LIP, RBILD, maybe is not so idiopathic, it's smoking related. And known causes, as you can see, would be collagen vascular disease, occupational, drugs, smoking, granulomatous malignancy, infection, and other. So the crucial thing in terms of figuring out what diagnosis you have is on the right side, is really identifying what possible associations they have with this patient. And this is the clinical context. This happens before you look at the CT, really. Or, because if you get a CT, which we usually start with a case because that's how it's referred, and start with that, it's more difficult. What you have to do is to sort of reset, go back to the beginning, and systematically go over each one of these things. And the clues are in here, because if they're not in there and you've really done a very, very good job, then only then can you say it's idiopathic. So these are the clues, which we can briefly go over. The clinical presentation, we'll go over that in a minute. The course of the disease. Sometimes before you even get to occupational, you know the answer based on that. There's a case that somebody presented me in Czech, I forget who it was, diffuse interstitial process. And then the X-ray 7 days earlier was negative. I think you're right. Mm-hmm. And that was, it was ARDS as an example. So, the clinical context is, the environmental history is very important. Occupational history, we'll go over that in a minute. The drug history. The demographics are often a clue. Not always, but sometimes they can help. Smoking history is important, and we'll go over that. Family history. So now, when you get to physical exam and data, you kind of should have honed in on a set number of diagnoses before you even get to that. Then it makes your job easier, and the lab data is oftentimes merely confirmatory to your clinical suspicion. So let's talk, for instance, about the time course. You can separate ILD into acute and subacute. Acute has a limited number of diagnoses, so this is an easy one. If you can look at the previous x-rays, you can get a Harmon-Rich syndrome, or AIP, which is basically, idiopathic ARDS with diffuse alveolar damage. HP, acute HP, diffuse alveolar hemorrhage. But the most important thing is, most of the time, you're really going to be concerned about infectious etiologies when you're evaluating ILD that happens in a 1 to 2 week period like that. More commonly is the subacute disease that sort of happens chronically over months to years based on the story you get from the patient about when their shortness of breath first began. It usually starts just a little bit exertional, and maybe the family knows this at first because they sort of subconsciously, slow down and don't recognize the shortness of breath until they get deconditioned enough where it shows up. So usually it's underestimated how long it's been going on for. But and also age, gender, and race. Age mostly can sort of give you big categories of diseases that are more or less likely to occur. Now, in the history, we'll talk about the past medical history. Sometimes it's important to establish a medical problems that have been associated with interstitial lung disease. And many times, these diagnoses are not in the patient's past medical history yet. So it's useful to establish the diagnosis on your own sometimes. For instance, let's talk about rheumatoid arthritis. They may not have a diagnosis of rheumatoid arthritis yet. This happens a lot. They'll come to you because of the shortness of breath or whatever, or the interstitial process, and you go over the review of systems, and you come up with maybe they have morning stiffness. These are the criteria for RA, arthritis, symmetric arthritis, greater than 3 or more joints for 6 weeks. Maybe they have some rheumatoid nodules on their elbow or something. The lab value shows a RF titer or a CCP level. And on physical exam, you might see the characteristic changes. So sometimes when you're approaching the ILD systematic like this, you also need to do a careful review of systems and discover other medical problems that may not be on their list, which actually happens more often than you suspect. Sometimes they may come in, they have arthritis, have been diagnosed with osteoarthritis, and it turns out it's RA, for instance. So interstitial lung disease in RA, those patients present with exertional dyspnea. Very often they have a non-productive cough. And usually it does follow the arthritis, but in 1/5 of the patients, they may come with interstitial lung disease first, so that makes it a little more challenging. And they may be asymptomatic until it's advanced because of the insidious nature of it. On exam, again, you'll get your basilar crackles that kind of get better as you go up to the upper lung fields. They sometimes do have clubbing as well, which kind of overlaps with IPF sometimes. We all know that TNF-alpha does play a significant role in the pathogenesis, and the mechanism of the lung injury may be the antigen-antibody complexes initially that go into the lung, cause the injury, the neutrophils come in, and later the lymphocytes come in and cause your interstitial lung disease. Now, you can't necessarily, this is another example of how you can't really start with an x-ray. You have to start from the beginning and go forward because it can present in many different ways. It could present with bibasal or reticular nodular disease in the upper left-hand corner. You could have pleural effusions and some nodules right upper, left lower, ground glass pacification. That would be kind of like NSIP if you got the biopsy. You can have some discrete rheumatoid nodules, and they can even be cavitary. And if you got a biopsy that thing, you would see a necrotizing granuloma. We have palisades of monocytes sort of perpendicular to the area of the necrosis. We don't see a lot of these nodules, but and again, it can present in many different ways from a pulmonary perspective, making it much difficult if you were starting from this first. For instance, parenchymal, you can get UIP even. We'll touch on that briefly. NSIP, these are all the biopsy results. You can get organizing pneumonia. You can get an LIP pattern. I don't know so much about the chronic eosinophilic pneumonia thing. It's probably just case reports. That's not very common, but you can get apical fibrobolus disease and the nodules. Now, the other kind of confusing thing, if you look at all the literature, is methotrexate can cause the disease, which is also the drug that is used to treat them. So if you look at interstitial lung disease in RA in the literature, it's kind of annoying to look at that because a lot of these patients are on methotrexate. So who knows which one caused which, but that's been known to cause lung disease. You can get airway involvement, like the cricoretinoid arthritis, and the other one's listed in pleural disease. So it's just an illustration of how you can get different manifestations from the same disease, and the importance of which would be the history that you got, the past medical history, to establish a disease in the first place. Makes the job much easier. And then you can do the same thing with other diseases, scleroderma. So these all have characteristic criteria in which to diagnose it. Like we won't go over all these. That's out of the scope of this, but we know systemic sclerosis can be seen very easily at physical exam. So you just have to look at their skin thickness. It can express as ILD, as pulmonary hypertension, as and it can be a limited or diffuse disease where you might just see it on the hands and the face, or diffuse. Now the point of this is that this was a study that had about 500 patients and 92 got biopsies, and they showed that there was a distribution mostly NSIP, maybe a little more limited than diffuse. But the point is that some of them, not many, but some had UIP. So if you start with this, then you end up with idiopathic IPF, when in reality, this was the biopsy seen with this disease. There's been biopsies from other autoimmune diseases that have this fibroblastic foci and characteristic of ILD kind of thing. And the implications of that is that this one might respond to steroids, for instance, or treatment, whereas the other one would be early, referral to transplant, right? So it's important to not to apply the histology within the clinical context, especially in ILD. It's very important. And again, there's multiple manifestations from a pulmonary perspective from scleroderma. We can get the pulmonary fibrosis, you can get PH, there can be pleural involvement, bronchiectasis, etc. So let's, as an example, give a little case report. So the patient has exertional dyspnea that is now shortness of breath at rest. 62-year-old man. For 3 years, he's had intermittent episodes of dyspnea. Described several episodes where he gradually, over a 1 to 2 week period, developed increasing dyspnea on exertion. No fevers, chills, myalgias, cough, or sputum, or wheezing, or hemoptysis. And most often these episodes would improve on their own, but he had also been given a few courses of steroids with improvement. No known triggers to the dyspnea, except perhaps being more frequent during the winter months. This is kind of the typical story we get when we're taking a patient's story, right? And then we go over this: past medical history, none; medications, none; social history, non-smoker; physical exam, healthy; afebrile; inspiratory crackles at the lower lung, So, we don't know what's going on, right? This is just an example, and then you get the X-ray that shows ILD. So what do you do? I mean, it seems like we have a diagnosis of ILD, but we haven't gotten any further. This is a more obvious one, but it just goes to show, if you don't know what's going on by the time you get to this, there's something else in the history, or it really is truly idiopathic. But that's not as common, So what if I put the occupation up? Dairy farmer, 50 cows, 80 things of hay, right? And that's why it always happens in the winter. So this would be HP. Before we even look at any biopsies or serologies, right? I say this is an easy one because in 50% of the HP, you can't identify an agent. So it makes it much more difficult, more challenging diagnostically to figure out what exactly it is. But if you can ask the right questions, you can get it. I mean, he didn't offer this story. He didn't. You have to ask them. I mean, they're not going to say, "Hi, I lick maple bark." It's maple bark causes HP. Anyway, or the patient that came to me a couple months ago and had diagnosis of after I think they called it AIP, and then it turned out he went on a vacation. There was a hot tub in there, and it was probably HIP based on that. So you have to ask questions that they may not offer. And again, the X-ray shows the bibasal or reticular nodular, more reticular interstitial process, and then the CT of this patient showed the ground glass. And here's the biopsy. So by the time we get to the biopsy, it merely confirms what we suspect, because it went through the clinical context to get to this, and it shows the loose granuloma there surrounding other tissue, the other tissue which has a little lymphocytic infiltration and a little inflammatory within the alveolar septi. Not totally normal, but.
Is there air trapping of that kind of scan?
Well, you can't necessarily tell like this. You'd have to do, inspiratory expiratory bills, and if you saw an expiratory bill, it could get more. But that's another finding in HP, is sometimes you can get the air trapping as opposed to alveolitis itself. I can't remember if he had that or not, if he had expiratory view. So HP, the more obvious ones that we know about are like the pigeon breeders, or if you're working in the silo with not just any grain, but decaying grain, and also other things we may not think about as much. But like for instance, toluene is a molecule that is because HP is mostly organic antigens cause a characteristic response, an inflammatory response, like a type 4 immune response to the antigen. So this antigen here can sometimes cause HP, and you'll notice that it is involved in various manufacturing processes. So even at this level of the history, it's important to get some of this stuff, which is hard to tease out. I mean, if they work at apparel, but they just box things together, they're not going to get exposed. What they're actually doing in these jobs is important. There's many causes of HP. The major causes you can split up into a type of antigen. You could do it this way, like thermophils, and the source would be, like I said before, moldy hay or grains that are decaying, and some of those diseases are on the right. Farmer's lung, mushrooms, works of lung, humidifier's lung. Certain types of molds can do it, and certain types of animal products, as we discussed. And again, the toluene I find is interesting because you don't always think about it. In our case, where we have a lot of auto workers, we think of the paint more of an asthmatic or a RADS kind of a thing, but that has been changed because of I think the original thing was carcinogenic, so they changed it to toluene. So now there's toluene, diisocyanate in there. This is from '89. A patient came in with HP. He was a spray painter for a car company. And I'm not going to get into the whole details of the case, just to point out an example. So they did a BAL. You can see that the normal BAL is 80-85% alveolar macrophages. So he had a lymphocytosis when he was symptomatic here. and the CD8 count, 84%, right? So there's a high CD8-CD4 ratio. You don't always see that, but in the more acute inflammatory reaction of the HP, you'll get the high CD8-CD4 ratio lymphocytosis in the BAL with HP. Compare it to sarcoid, right? We have a high CD4, CD8, which is very specific if that ratio is like greater to about 3.5 for sarcoid. And here's the same. This is IgG level. So the guy was hospitalized. The same guy went up, and then he didn't get any treatment of any kind. He just got a little bit of steroids and went back to work with a mask because he had to go back to work for economic reasons and wore a mask. And then he got better, and interestingly, his IgG came down. Another way of looking at this when you approach the way you're going to approach somebody with ILD is you can separate into organic and inorganic when you're talking about occupational and environmental, which go together really. So we talked about HP, that's organic. There can also be inorganic ways of injuring the lungs, and that's known as the pneumoconioses: asbestos, silica, iron, coal worker. Silica is the most abundant mineral on Earth, so any occupation that disturbs the crust of the Earth will expose one to silica. Sandblasting, mining, foundry workers that actually make the dye to put the molten stuff in, that stuff is made out of silica. People who do the sandblasting also includes the people that do that in the car, take the paint off. Nowadays it's done like in this thing, so it's closed off, but that was historically something that could cause that. And the production of the ceramics it has to be heavy duty production of the ceramics, not necessarily working as a hobby, but that contains silica, the dust. And you can get simple silicosis, and then when the nodularity sort of come together and conglomerate, you can get conglomerate silicosis, and you'll get sort of an upper lung zone predominant fibrosis towards the end. And this is another important point about getting, we know this to get the story early on because it doesn't sometimes express itself until 10 to 30 years later. So what they did for a living 5 years ago may be irrelevant. And we know the various industries and occupations associated with asbestosis, anything that involves insulation really in the old days. Insulation of pipes, pipe fitters, steam fitters, boiler makers, etc. Now, you can see there's the histology being on the left. It's really limited what the histology is that you see. So it really is again important for the clinical context. So IPF, which is UIP, you can get that histology on a biopsy. In patients that have asbestosis or uranium mining, plutonium, mixed dust, that can cause IPF. NSIP, any organic antigens can cause an NSIP-like histological finding. Discriminative interstitial pneumonitis, textile work, aluminum welding, inorganic particulates, the old form of BOOP, which we now call COP, which is, what's the word? Not really correct because it's not cryptogenic, but alveolar proteinosis is associated with silica. Who took the boards this year? I think that was one of them. Silica causing that, right? Giant cell interstitial pneumonitis. I think that was, this one. We had a previous fellow that did this one, so that's what that finding was, pneumocirrhosis. Now, the other important point sometimes it doesn't help to hone in on the diagnosis, but a lot of times it does, which is the smoking history. The ones that have high associations with smoking, as we know, is RBILD, respiratory bronchiolitis associated interstitial lung disease. Usually an upper lung zone predominant finding with some ground glass on CT associated with smoking. Eosinophilic granulomatosis, or EG, is the other one that's highly associated with smoking, but IPF is also associated with smoking, actually. Most of these patients with IPF are smokers. Now, interestingly, a low association is sarcoid to a lesser extent, but HP has been classically shown to be associated mostly with non-smokers. There's many studies on this. This is just showing one where they have an IgG level to anti-pigeon, and the smokers had a lower antibody level versus non-smokers or ex-smokers. So there's an inverse proportion, but that's why sometimes it's useful if somebody's a heavy smoker and you're on the fence. It may not rule out HP, but if you're not sure what's going on, it might help to fine-tune exactly what your pretest probability is for HP in that patient, for instance. Now, in rheumatoid arthritis, actually smoking is correlated to lung changes as well. The FVC, the DLCO, and the chest X-ray changes are much more prominent in terms of percent of patients who have abnormal findings if they have a higher pack year, and that's compared to non-smokers. So there's also association there. Now, age and gender can sometimes help to determine the most common interstitial lung process the patient might have. Young age would be associated with sarcoid or connective tissue disease. And IPF is really a disease in the 5th, but more of 6th and 7th decade is the more highly. If you have someone that's younger than that, it can happen, but it's probably something else going on. Somebody comes in with pulmonary fibrosis and you get a biopsy and it shows UIP and the patient's 40 years old, you might want to look more carefully into collagen vascular or something else. Females, LAM, tuberous sclerosis. Males a little bit more with rheumatoid lung and with the pneumoconiosis, but that's more likely related to occupational choice as opposed to anything genetic. Sometimes the family history is helpful. We talked today about the sarcoid patient, but there is a subset of IPF patients that have a family history, a genetic type of IPF that is being studied. There's a registry being developed, and there may be a clue in that. It's not very common part of it, but it is there. Now, the drug history is also very important, and it's also important to look at drugs they may not be on anymore, which is a lot harder than Epic now, when you say drugs taking, not taking it. So you have to actually ask them and go over what drugs they were taking. This is a high chance of missing it too, because a lot of times the patient doesn't know what they took, in the past. But there can be there's a temporal relationship. You also have to look at over-the-counter meds. You have to look at whether they took oily nose drops, which can predispose you to what? What does that give you? If you're taking nose drops for a homeopathic reason, what could you get? Lipoid pneumonia. Some have a very long latency period. Amiodarone, we talk about that a lot, can happen 2 months after the therapy, and that can be difficult to hone in on. And of course, there's many different drugs that cause it, and you can split it up. It's easier to sometimes split it up into types of drugs. I listed the more common ones here with regards to drugs that are more commonly associated with interstitial lung process. But basically, if you go into a book, there's many of them. I mean, this is A through B right here, and this is the different types of lung manifestations. So basically, the answer is to go to pneumotox.com. If you're wondering if a certain drug is related in a patient you're working up for ILD, you type that in and it'll give you the more common pulmonary manifestations with the references. So it's very helpful, actually. There's actually a pneumotox app, which is the same, kind of the same thing. Rapamune, right? You guys that go through transplant might be familiar with this, right? It can cause an interstitial pneumonitis, lymphocytic. Okay. All right. So again, other etiologies need to be ruled out, like infection, primary lung, and ideally you need to document improvement after drug discontinuation, and that the symptoms recur on re-challenge, which many times we don't see because we don't re-challenge them. But the time course can be either subacute, which is 1 to 6 months after the drug, but sometimes, which just makes it a little more challenging, is sometimes it can happen 6 months or years later. And sometimes it's dose dependent and sometimes it's dose independent, so that oftentimes doesn't help. And the presentation is often non-specific as well, where they'll get the dyspnea, non-productive cough, fevers. They may have eosinophilia, which may help. You may see reticular nodule opacities. There may be more of a ground glass component on CT, and you may get eosinophilia in there on BAL. And in conjunction with the clinical story, it might help you to hone in on that, on your suspicion. Then you stop the drug and it should go away. Now we're all the way into this talk, and now I'm starting to talk about the patterns of the X-ray. So that shows, again, reiterates the importance of clinical context, because once you get to this point in the patient's story, you should at least have some, guesses as to what could be going on, and this stuff should rule in or rule out those short list of suspicions that you have before you get here. So there's pattern recognition. So basically, let's talk about this. 35-year-old African-American man, progressive shortness of breath, carpenter, lifelong non-smoker. So what do you see, Murad?
I would suspect sarcoidosis.
Yeah, and I could have just put the X-ray up, and we can do that on Friday, but I put it in the clinical context, right? Now, what about this one? Same thing, right? You see polyradinopathy, the upper lobe predominant. But what if there's a 43-year-old African-American progressive shortness of breath, works in the fluorescent lamp industry? Borreliosis, which gives you something that looks just like sarcoid. So the story, I have a patient that has sarcoid for a long time, and I finally honed in a little bit more. And what he was doing is he works with borreliosis. So that guy,
Yeah.
he's white and not very symptomatic. So interesting, it might be different. It's a different disease,
What test would you run?
Yeah, I ran that on him too, by the way.
Something with the
No, it could be in serum. It's in
Lymphocyte-
serum.
in serum. Lymphocyte something.
Yeah. Lymphocyte proliferation test. You give the beryllium to the lymphocytes and see if they act up.
Lymphocyte
And
inflammation.
I think you measure like TNF
You know
alpha.
where you need to send it?
What?
You know where you need to send the test?
Where?
Cleveland Clinic.
Okay.
That's where you do it.
Yeah.
It is on-
Now talk about pretest availability. And that's a live lymphocyte, so that's what my justification was, because the test was negative on that guy that I said was exposed to beryllium, but I ignored it because the beryllium exposure was so strong in this guy. About this one, it shows a bunch of bibasilar stuff, right? Reticular nodule infiltration, fibrosis. You couldn't really say much to do, but then you get that story. It's easy, right? So again, this is X-ray patterns, but always within the clinical context. It makes it much easier. What about this one? There's not going to be too much clinical context here. It's just pattern recognition. What do you see there? What's the distribution of the abnormality, of the opacity? Is it medial or peripheral? Peripheral. So if you see peripheral like that, almost all the way down, right? And it's what? Yeah, chronic eosinophilic pneumonia, right? Where you get, and the story might be some malaise, and for a couple months malaise, and maybe a little exertional dyspnea. Not as much as you think, compared to acute eosinophilic pneumonia, which by definition is intubation, really. That's respiratory failure, and it goes away, doesn't come back. This one responds to steroids, but comes back a lot, and it's a different disease than the acute one, but that's pattern recognition. High-res CT, we can look at the distribution of the abnormality, upper, middle, lower, medial, peripheral, and we can look at the type of abnormality. This might be slightly more basic for the third years, I guess, but so you can have ground glass, honeycombing, and you can have traction bronchiectasis. I guess those would be the main things to look at. Honeycombing, looks like honeycombing, I guess. There's cysts if you go up and down, because sometimes you can't tell the difference between a honeycomb and whether that's just a dilated bronchi. So you have to scroll up and down with the CT and see if it ends, if it's a cell. If you can follow it up a little bit, it's a tube, right? But in general, these are more obvious pictures. Sometimes they're not as obvious, but honeycombing is there. That's indicative of fibrosis, for instance, in UIP. You can get cysts, and here's the LAM. There's a spontaneous pneumo setting of that. the cysts on the left, all are basically the same kind of look, right? I didn't have a name on it for EG. Compared to EG, where the cysts are all different shapes and sizes, both of them are limited to usually the upper lobes. You can get manifestations of nodules. The one on the right is sarcoid. The one on the left, I think, was HP. In the acute going on to subacute HP, you can get sort of a micronodular, loose ground glassy kind of a look to it. And we all know what ground glass looks like. It's a hazy pattern that does not obscure the underlying anatomy like a consolidative process would. Now, why that would be important has implications for treatment response. It's been shown in multiple studies. I just put up one randomly that the chance of improvement in lung function after steroids is much higher when it's pure ground glass. It's a little lower when it's mixed, and when you have a reticular pattern, which is indicative of fibrosis, the response is for significant lung function return is low. So we talked about clinical presentation, which then leads us to the radiographs. By then we have some clue of what's going on, perhaps, and then the question is what to do next in the workup, and that would be proceeding to a bronchoscopy or a lung biopsy. So what is the role of BAL in interstitial lung disease? Sometimes it can be very helpful, depending on the disease you're looking for. If you're looking for infections, it's very helpful, of course. Things that, I didn't include all infections. I mean, infections that kind of masquerade as an interstitial process and you're not sure what's going on, And that would be things like PCP, fungal can do it, viral pneumonitis, although those people are usually very sick and it's pretty obvious that they have that. But nonetheless, that would be a quick diagnosis. PAP, where you get, it looks like ground glass, the crazy paving where you get spots of abnormalities throughout the lung, can be diagnosed very quickly with BAL because you get a milky effluent and you get PA positive cells that come back and you get the foamy macrophages. Diffuse alveolar hemorrhage, you get that by putting in a BAL, seeing nothing in the airways usually, and then getting back the bloody return that does not clear with aliquots and serial BAL. That would be your diagnosis. You can sometimes even send off red cell count numbers throughout, but usually it's more obvious that it just simply doesn't clear in color. And that would be your DAH. That one also presents with a diffuse ground glass looking appearance. If somebody has like a epistaxis or other bleeding that way, and they aspirate into the lung, it can cause ground glass too, but that would clear with the BAL. So that's how you do that. Malignant cells, obviously, you can diagnose. Very rarely can you get dust particles in asbestos bodies, but that's on the list of things that can be diagnosed that way. I've never heard of anybody diagnosing that with a BAL, but obviously any eosinophilic lung disease, you're going to get eosinophils, including drug-related too. So we talked about beryllium. You could do it in serum. You could also do it in BAL. I've never done that, but and then eosinophilic granulomatosis, you'll get CD1A cells are normal, but you'll see a lot of them. So that's indicative of EG, for instance. Sometimes it doesn't diagnose it, but it's used to continue to hone in on your diagnosis. And those diseases would be things like HP. We talked about if you have a lymphocytosis, you look at the CD8-CD4 ratio or sarcoid to CD4-CD8 ratio. In advanced sarcoid or advanced HP, it wouldn't be helpful because they don't have much lymphocytosis by then. In acute HP, it may not be helpful either because mostly it's neutrophilic at that point. But subacute HP, it's been helpful, so it's a subset. Neutrophilic means there's something quite inflammatory going on, and acute brings you back to infection, but also the non-infectious would be like acute interstitial pneumonia or ARDS. And then eosinophilic, obviously, is an adjunct, and the most important thing oftentimes is not finding an infection as Tamim alluded to before that. So that's going to be very important to rule that, get that out of the way before you move on. Now the question is, do you need a biopsy? And if so, what kind of biopsy? Well, I had this slide for many years from Kevin Leslie. He's out of Colorado, I think. Very helpful in sort of conceptualizing what role you might have with a transbronchial biopsy and when you need to do a surgical. So these diseases, you often will get the diagnosis if you do a TBVX. Sarcoid or granulomatous disease, very high yields if it's sarcoid of having non-casing granuloma in those bites. Malignancy, obviously, especially if they have findings on the CT that shows it's extensive with the lymphangiatic spread, and you're thinking it's some kind of ILD, the TBVX will help for that one. Any cause of diffuse alveolar damage, you'll see it. You don't need a bigger piece for that. Alveolar proteinosis, eosinophilic, with the staining you'll see eosinophils. Now, and these, well, you'll sometimes get them because the whole entire area is not always involved, like in vasculitis or capillaritis. But if you do get that piece, it's characteristic. So you can sometimes get it, but it's more of a yield thing. These things, I don't know about never, I would say rarely. Notice that COP is there, but we see a lot of COP-like injury constantly, right? And really, usually, that's why it says COP-like. You can't really diagnose it without a bigger piece. Yeah, I mean, you need the whole Acinar process, really. But so these you go to, and oops, sorry. So surgical biopsy for all of them. So that helps to decide what to do. Now, okay. Looking at the just to go further into the biopsy thing, a study done out of Michigan a while back looked at diagnosing IPF by using just CT alone, and they had 73 patients that had UIP, 23 had NSIP, and they independently reviewed the high-res CTs, the biopsies had already been done, and they had them record them radiographically as whether they thought, based on the pattern, that it was definitely UIP, definitely NSIP, or indeterminate. And they found that all the patients that the radiologist said had definitely UIP, they all had UIP on the biopsy. But patients that they looked at the CT and they said it was definite or probable NSIP, 60% of those had UIP. So what that, and subsequent studies confirmed this in different ways since then. So what that meant was that if the CT was classic for UIP, there's no reason to get a biopsy at all. And these numbers have borne out since then. So, but even if you think it's NSIP, even if you very highly suspect it's NSIP, in a lot of those patients, the biopsy come back UIP. Now, this is probably why. If you get a biopsy in the upper and the lower, you can have discordant histologies. You can get NSIP in one and UIP in the other, or you can get UIP in both. And the reason why reading the CT is read as NSIP and sometimes it turns out to be UIP is probably because that ground glass is actually fine reticular pattern, which is actually the fibrosis. And this is sort of a separate point to show that the prognosis. This is why if there's some element of confusion, you do need to get the biopsy, because if you have NSIP in the upper and UIP in the lower, and UIP in the upper and UIP in the lower, the prognosis is the same. The one on the left does just as poorly as the one on the right. The analogy could be that if you find somebody with lung mass and you have a normal area here and you have cancer here, it's still cancer, right? And in a way, IPF could be a sort of a cancer of the fibroblasts. The fibroblasts never undergo apoptosis, they don't die, they just keep making scar for unknown reasons yet. So it is kind of like a cancer. Now, on to briefly the histology. Again, another example of, you have to have the right clinical context, because there's sort of a limited number of histological patterns, but there's many diseases associated with the same pattern. So, we talked about LIP, RA and Sjogren's syndrome can characteristically give you that pattern. NSIP, basically any autoimmune disease, any misconnected tissue disease, any lung injury in general can give you an NSIP. That's why they call it non-specific. And it's an inflammatory pattern involving the alveolar septi in more or less of a homogeneous distribution. And then UIP, which there is very little inflammation, and you have areas of fibrosis in the alveolar septi with very little inflammation. You have an area of fibroblastic foci, and you have minimal inflammation. But you can sometimes get that pattern in autoimmune diseases. I think I'm gonna have a picture. This is a UIP where you have a fibroblastic foci here, which is kind of the leading edge theoretically of that fibrosis making machine, leaving behind the scarring without any inflammation, and then there's normal tissue over here. And this is rheumatoid arthritis. There's a little more inflammation, but that's a fibroblastic foci. So histology alone doesn't cut it. And why that's important is, of course, because the prognosis is much poorer in the truly idiopathic UIP, where 50% are dead in 2 years, and that hasn't changed much over the years, actually. And there's a better outcome with the NSIP. Again, the prognosis of the same histology, or relatively same histology, showing UIP in both. The prognosis in the collagen vascular UIP is much better, and the idiopathic UIP again is bad. So clinical context with the same histology is the take-home point. Is that we arrive at the we're given the CT or the biopsies first when they come to you, but then you have to sort of semi-ignore that a little bit and just go back to the very beginning of the story. Start from the beginning and then get back to this. So, in sum, the way to approach ILD is, I guess you could say forest histology, but really the main take-home point is it really has to be done within the clinical context. With ILD, that's more important than maybe other diseases that, other situations that may not be as important. But without the clinical context, they all are idiopathic, And the tempo of the disease is very important in determining the type of ILD, as we talked about already. The radiographic findings have certain patterns. Each one of those would be a separate talk, which will go on throughout the year. I don't know if Christian's giving another talk or something, but different patterns, like for instance, what's the radiographic pattern for a UIP? Where is that usually? Location, lower lobe, basilar, relative sparing in the upper, sparing in the medial, right? Peripheral gets worse as you go down, which on clinical exam is exactly the same, right? You'll hear, that's how you can write how I write mine. Crackles at the bases, which diminish or become more clear as it goes up. A third of the way up, I have basilary with sparing in the medial. That's very specific on physical exam, actually, interestingly, for UIP. So that would be a pattern of, and then a pattern where you have grand glass in the upper lobes is what? Depends, right? It could be smoking related. Acute HP can sometimes start in the upper, and then as it gets more involved, it can involve the basilar. Eosinophilic granulomatosis, pneumoconiosis upper, except for which one? Asbestosis is lower. The rest of them are upper. Those kind of things, right? So that's radiographic findings, and we talked about histology. I think that's basically it.
I have one question. You didn't cover it, but I was hoping you'd cover it. The blood tests that are done in these patients with ILD.
Yeah.
Sometimes I look at rheumatologists came down to the floor and ordered a whole bunch of tests on the patients. So I asked the house staff to please ask them, what is the purpose of all of these tests? How are they going to help?
Yeah. Well, interestingly, it's true that, and the rheumatologists will say this too. Like, if you send them a patient that has a high ANA, they'll kind of ignore it unless there's something in the clinical context to say the patient has lupus or rheumatoid arthritis with a symmetric stiffness. The other thing you hear, let's get an autoimmune panel and stuff, but the autoimmune serology, unless it's really high is not going to get you your connective tissue disease diagnosis necessarily. In fact, there's an entity of UIP that has a high ANA level, and those patients don't have lupus. They just have an ANA level for whatever reason. They have a very poor prognosis, and it's good old-fashioned IPF. So in a vacuum, the autoimmune serology is not necessarily going to get you anywhere closer without the clinical context. So getting a bunch of stuff in and of itself, if that's all you do, can't do it. But you still should do it. You just have to put it into context.
Let me pick on Dr. T for a minute. Did you hear that?
Sometimes in that same patient, you ignore the ANA.
Right.
Still do it.
Yeah, we do it, but we do it in everyone. Let's say you can do it in everyone, but then you have to say, in that patient, the ANA doesn't mean anything. In that patient, that's lupus,
Right.
with the same ANA level, depending on the situation, right? So it doesn't mean you don't get all these tests. It just means you smartly plug it into the context in which you created it after getting a very careful history from the patient.
But we know that 5% of people can have positive ANA without rheumatologic disease. But in someone who already have interstitial lung disease, I would take a positive ANA more seriously.
Yeah, that's a
and
clinical
investigate more.
It would. In other words, you'd have to say that the interstitial process is a red herring, which is hard to say.
Yeah,
Right?
I'm not talking about the basic ones, A&E and this.
Or
Some of those other ones that I've never heard of in my life.
Like what?
I can't remember what they
It depends what it is.
They had like 12 of them.
But some of them are specific for certain autoimmune diseases, so they, you would just basically diagnose the patient.
In the context of not even thinking that might be possible. You say we're just
Yeah, like if someone had like.
I think maybe
them,
the rationale is because it's worth looking. I guess it's worth digging deeply, depending on what the pattern is on.
correct,
on
correct, I understand that. But when we asked them
potentially
specifically,
Which one of them?
what does this mean? They couldn't answer the question. They could not answer.
Yeah, like if you have a diagnosis on the histology, if you ever get to that point in the
They
patient,
didn't understand why they were getting the test.
and you get LIP back, right?
So you need to understand why you're getting the test, what you're looking for,
Right.
how do you think it's going to help you manage a patient. If you don't know, you shouldn't be ordering the test.
Yeah, it has to be done through the clinical context. Yeah.
Correct.
What were you saying, Dr. LIP? What?
Well, like it would LIP, like if as example clinical context, and then you get, like an SSA level or something. That's Schrogen's
Right.
presenting with LIP. And there's another example, the one you presented, Aaron, in that clinical whatever.
Yeah.
That one, I don't remember the details, but that was very acute, right?
Yes.
And that said to me that it wasn't like IPF or something.
Well, actually,
And I said that to myself, even while Chad Stone was saying it was. I think he
no,
said,
but actually,
so I ignored that
when
because
we
the
actually
X-ray was
got
like.
more history.
Yeah.
It wasn't the exacerbation of it was acute, but he actually had been having symptoms for years. But it's because that was the disconnect. Once we got more history after he got off the ventilator and we talked to him more, he actually had more history that was suggestive more of UIP. Because initially that's what Christian and everybody thought, that this is too acute for it to be.
Yeah.
Yeah. But it turns out it was actually an exacerbation of UIP.
That one's also a good clinical story because that one's you have to rule out the stuff. It's hard to. There's no blood test for UIP exacerbation.
Thank you, Dr.
Okay.
Thank you very much.
Thanks.